One of the important aspects of voluntary informed consent is disclosure and understanding of, quote, sufficient relevant information, unquote. Post and Bluestein make 3 points about what sufficient relevant information might mean. First, and most obviously, they say that this refers to facts about the proposed diagnostic or therapeutic intervention, facts that patients typically consider relevant. Now, Post and Bluestein don't specifically use the language of benefits, burdens, and risks related to treatment, but many discussions of voluntary informed consent do. To make a good decision, patients need to know what benefits they might expect to derive from the intervention or therapy and what burdens are associated with it. What's the probability of various levels of benefit, and what's the probability that they will, or the risk that they will experience significant burdens related to the treatment. And of course, they need to understand the possibility and probabilities related to the progression of their disease. Secondly, they need to know the implications or the consequences related to alternatives to the proposed intervention, or even the consequences of non-intervention, of non-treatment. So as we've already seen, very often there are multiple treatment options. A truly valid informed consent will be based upon an understanding of information not simply about the therapy proposed, but about alternative therapies, and even about no therapy or no intervention. What will happen? What are the potential benefits and risks to me if we do nothing but let my disease or my injury take its course? And finally, they say that it's appropriate for physicians to make their specific recommendation as to what the patient should do. Some measure of appreciation here, I think, for the power imbalance between a knowledgeable healthcare professional in a context in which he or she is quite comfortable, and the power imbalance between that physician and a less informed, ill, anxious patient is appropriate. For some patients, their anxiety, their fear, their humiliation, the unfamiliarity of the medical or the hospital context in which they find themselves will lead to their forfeiting of all authority and control to the physician, or the forfeiting of their own self-determination, and a throwing of themselves entirely into the hands of physicians. Now, they surely have a right to do that, but healthcare professionals should be cautious in making recommendations and do their best to offer patients the opportunity to become competent and confident participants in decision making. So, voluntary informed consent is obviously a very important requirement in the medical context, but you should notice the 3 exceptions that Post and Bluestein identify. The first is emergency situations. In situations where life and health are at profound risk, where time is of the essence, and where a patient is unable to participate in a timely fashion in decision making, one need not have voluntary informed consent to intervene to treat a patient to save their life. Secondly, they note rare situations where disclosure of information will in fact cause a patient, quote, imminent, direct, and significant harm, unquote. Now, notice they're talking about a psychologically or emotionally unstable person. And also recall the distinction that Post and Bluestein have made earlier between distress and true harm. Just because disclosing, for example, a possible risk associated with some treatment or some aspect of the patient's prognosis, just because that disclosure might cause distress, Post and Bluestein have warned that we should not assume that it will actually harm the patient. Distress is appropriate in the face of such difficult information, but that distress may not be truly harmful. However, there are situations, they imagine, in which it could be harmful to a highly unstable patient. In those situations, there is a justification for withholding information and having something less than informed consent. Finally, notice, of course, here Post and Bluestein's acknowledgement that patients do sometimes choose not to participate in decision making, and they surely have that right. Again, you should worry about the imbalance of power in the situation that will sometimes cause a weak and humiliated patient to too quickly abandon their capacity for self-determination and throw themselves into the hands of their healthcare providers. You should, by now, understand what voluntary informed consent is. You should understand its moral basis in those moral principles that we are using. And now you understand something of the information that must be disclosed to patients and understood by them if we are to actually have voluntary informed consent. Next time, we're going to look at another key element of informed consent, and that is decisional capacity. What does it mean to have decisional capacity? Only patients with it are capable of giving voluntary informed consent.